Good evening, everyone. My name is Pat Streeter. I'd like to welcome everyone to today's presentation of Building a Crisis Services System for All Michiganders, 988's and MiCAL's role. We are excited you could be here today to hear more about this system's implementation with two subject matter experts. The format for today's webinar will be a presentation with Ms. Hausermann and Ms. Zaguskin, followed by a Q&A period with all of you. Today's presentation is co-sponsored by MHAM's Partner in Crisis, NAMI Washtenaw County, and Fresh Start. At this time, all lines will remain muted until the Q&A portion after the presentation. If you have questions, you're welcome to drop them in the chat during the presentation or after we will address them with the presenters. During the Q&A, you can unmute yourself to ask your question. I would like to introduce you to our two presenters, Krista Hausermann, who is a Strategic Initiative Specialist at the MDHHS Behavioral and Physical Health and Aging Services Administration, where her primary focus is on enhancing the current publicly funded crisis services system through the Michigan Psychiatric Care Improvement Project, also known as MPCIP, and 988 initiatives. Krista is the implementation lead on Michigan's 988 implementation and the Michigan Crisis Access Line project. She has a master's degree in social work from the University of Michigan, as well as a certificate of integrated healthcare. Krista has over 20 years of experience working for community mental health service programs as a home-based therapist, community collaborative coordinator, clinical supervisor, and program manager for services for families with children with severe emotional disturbance, and over 5 years experience working on behavioral health projects at the state level. Also with us today is Rachel Zaguskin. Rachel graduated from the University of Illinois at Chicago with a dual master's degree. She received a Master of Public Health with a concentration in community health services and Master of Business Administration with a concentration of business management. Currently, Rachel works for the Michigan Department of Health and Human Services as a public health consultant, facilitating the Michigan Suicide Prevention Commission, which was initiated by Governor Gretchen Whitmer in 2019 and was officially formed in March 2020. Prior to the grant period ending, Rachel was the contract manager for the Michigan Suicide Prevention Lifeline Grant. She is also the state program coordinator for a new community violence prevention program that will be implemented this year with the cities of Kalamazoo and Grand Rapids, as well as the SAMHSA grant coordinator for 988. Welcome, Krista and Rachel.
Thank you.
Excited to be here.
All right, who will begin?
I'll go ahead and start us off.
Okay, great.
Thanks. So I'll start off talking a minute about this slide. This is one of my favorite slides, and I always include it in any presentation that I do around crisis services. So I'd like to just tell you a quick story to get us started. I've been working, as you know from my background, I've been working in behavioral health for a long time and in crisis services for the past few years. So recently, I had my own personal experience related to crisis. I had a very close friend call me up who knew what I did for a profession and call me up in a state of crisis needing some help. And so she was in the midst of a crisis and basically was saying, where do I go? Excuse me. Oh, so hold on. Asking me where to go. And so I sat here thinking that given my background and given that I just finished a survey on crisis services existing in Michigan, then, I should have a really good sense of this. And so, of course, the first question that I had to think of, and the first thing I thought of is, what type of insurance do you have? And so I sat here in the midst while my friend was in crisis, and I'm, wanting to support her and having my own reaction to her crisis, thinking through, oh my gosh, where can I send you? Let's think about where you could go to get help, and especially with private insurance. And then also, she asked me the question, she said, so shouldn't I go to the emergency department? And I'm thinking, oh no, you're not going to get any help there. And I knew from the area that she was at that she wasn't going to get any help there. So I always consider it the universe just reminding me of how important building out crisis services are. And I knew that, and I've always known that on a professional level. And again, it was the universe reminding me of how important that is on a personal level for all of us, that all of us in Michigan, any Michigander deserves the right to get the help they need when they're in a crisis. And that it's really not okay that the first thing that any of us have to do when either ourselves or a family member or friend is in crisis is we have to pull out that insurance card if we have insurance and really think about payer type. So because of this, many Michiganders end up going to what I consider our default crisis services system. That's the next slide. So for the last few years, the number one reason in Michigan for emergency room visits is psychiatric care. You can see that there were over 165,000 visits, almost 166,000 visits by Michiganders in 2020, and over 200,000 in both 2018 and 2019. Most of the people that go to emergency departments for behavioral health care end up leaving if they don't end up getting hospitalized, they leave the emergency department maybe with a piece of paper that has a referral on it where they can go and follow up and get help. The ones that are lucky have community mental health services that can provide them more extensive follow-up. The other default crisis services system in our state is law enforcement. Statistics show, and some research that I did showed that the percent of law enforcement contacts involving mental health range from about 1% to 17%. There's a huge range out there depending on the article and that you look at and the source of where those numbers are coming from. In Michigan, if we were just to take 2% of the calls to 911, then that would be over 172,000 calls annually. Because in 2019, there were 8.6 million calls. And many people estimate that 2% is pretty low. So again, as we know with law enforcement and EMS, they are not trained, or most of them are not trained to provide behavioral health support to people in crisis. This is why we really need a system that's for all Michiganders where they can access the behavioral health care they need in crisis, regardless of payer type. Next slide, please. Our current crisis services system is pretty fragmented. Just because you contact one crisis services system, say you call a crisis line, like even the National Suicide Prevention Lifeline, there's no guarantee that you will be, that your care will be followed up on, or you'll be connected well to other parts of the system. So it's not only enough that we can't just add new components to our crisis services system. We need to ensure that when we're adding crisis services, that they are integrated so that people don't fall through the cracks when they're receiving crisis services. We want to make sure that they get the help they need. Next slide. In Michigan, we're building a crisis system for all Michiganders, for anyone, anywhere, anytime. We're basing this crisis system work off of SAMHSA's model and the Crisis Now model. So there's three main components that we're working on. One of them is someone to talk to. That's in Michigan, that's our Michigan Crisis and Access Line /988. I say that because we'll talk more about 988 later, but Michigan Crisis and Access Line, those staff will answer 988 calls. So that's how they're connected, and that's an important thing to remember. So again, MiCAL will be the someone to talk to, and it will be, I'm going to go into more detail about MiCAL in just a few minutes, but basically it's a 24/7 call center. The second component that we're working on are mobile crisis teams, someone to respond. Right now in Michigan, there has been some legislation to develop some pilots for mobile crisis teams in communities, and MDHHS is working on developing those pilots and a request for proposal for those pilots. When those pilots are developed, one of their requirements will be that they connect with and coordinate with MiCAL, which is a good thing. The other piece in around mobile teams is there's also a My Kids Now initiative and the new Children's Department, which are also looking at mobile crisis response. And so that work is also being coordinated with the other pilots that are being done, and all of it again will be coordinated with MiCAL. So we are meeting together with at MDHHS, for meeting internally to ensure that our initiatives are staying aligned. The other thing I'd like to point out on each of these slides, I forgot I added this time, is the goal for mobile crisis teams is that 70% of those and 70% of the situations are actually resolved in the field. So other states have implemented mobile crisis successfully, and that's the statistic that they've managed to achieve. The same thing with the call center. 80% of calls that come in are resolved on the phone. They don't need any face-to-face follow-up or other crisis help in that situation. And that statistic, we are finding that that's accurate for MiCAL as well. The third component are crisis stabilization units. This is somewhere to go. And so this is a place that anyone in Michigan will be able to go and receive behavioral health crisis stabilization services in an emergency. I think of it like a behavioral health emergency room in a way. And the premise of these crisis stabilization units is that it offers a trauma-sensitive, calm environment that's really tailored to people that are having a behavioral health crisis. It allows time for that crisis to unfold naturally and to bring in maybe resources, community resources, family, friends, to really help that person's work through the crisis, along with, of course, the staff at the crisis stabilization unit. And also they will ensure that there's linkages to community resources when the person is hopefully discharged to the community. If we do this successfully in Michigan, again, our goal would be to have about 70% discharge to the community. This is the success that other states are achieving. They have found that people can be better served in a less restrictive environment, which ends up saving those psychiatric hospital beds for people whose needs can't be served in the community. So right now, MDHHS and a group of stakeholders are working on developing a crisis stabilization unit model and also a certification process. The Michigan legislature codified crisis stabilization units and basically required this service last year. So again, we're still working on the certification criteria. There's a lot of interest in this across the state. And part of the certification standards will be that they integrate with local mobile crisis and, of course, MiCAL. Another important piece of all these crisis services is that crisis is defined by the individuals who need the help. So people don't have to be in a state of crisis to the point that they need psychiatric hospitalization when they call MiCAL. They can be in distress. They get to define that themselves. We want them to reach out earlier for help. The other thing I want to mention about these crisis services is that as we stand them up, it's really important that we stand them up as a public good, similar to police or fire. And we also need to fund them as a public good. So you think about fire departments. They fund fire departments in such a way that the people are there all the time. The fire staff are there all the time to help. And they're waiting there. They're not funded necessarily by every time there's a fire. So we need to be thinking about crisis services in the same manner, that in a way so that everyone can have the services they need when they need them. And again, as I equated to fire, I think, can you imagine if you had a fire at your house and you called a fire department and they said, hey, you've called the wrong one, you know, we don't cover you. And so that's the kind of thing that's happening right now in behavioral health care. And that's what we are working very hard to avoid. So the other thing that I'd like to point out that's happening in Michigan around crisis services is that local level of crisis service hubs. We're seeing a number of areas where there is, maybe it's a local CMH or a group of community services providers and people with lived experience that are coming together, and they are not only offering one of these services, but they offer both mobile crisis and crisis stabilization, so that when MiCAL would call them and say, hey, this person needs more than we can handle on the phone, that they need a face-to-face support, then they would be able to take that person, we'd be able to work with that person and make a warm handoff to this crisis hub. And then they could, we would work together to figure out whether that person would be better off coming to the crisis stabilization unit, or whether they'd be a better served at a mobile team, or maybe they may need to go to the emergency room. There's a number of options. And so that's what we're seeing some communities develop, is a crisis hub for these face-to-face crisis services, so that again, they're all coordinated and you're ensuring that when that person is handed off to this face-to-face crisis services, that they're getting what they need. Next slide, please. Here's some legislation in Michigan. Our legislators are doing a great job of helping us develop a crisis services system through all these components. You can see here that at the very beginning that MiCAL came about through the Michigan Psychiatric Inpatient Discussion and also the CARES Task Force. Another component we're working on is a psychiatric bed registry, which will be integrated with MiCAL. And then you can see here the establishment of the Michigan Crisis and Access Line, which predates 988's. And then the requirements around certification. And then there's other legislation mandating integration between some of the crisis services. And then also the PA 162 and 163 was what I was talking about regarding the mobile crisis. Next slide, please. So MiCAL and 988, what's the difference? So as I mentioned just a minute ago, MiCAL was actually codified into law prior to the Federal Communications Commission establishing 988 as the 3-digit code for the National Suicide Prevention Lifeline. So if MiCAL had come a little later, or a little bit closer to the same time, then we may have ended up with MiCAL just answering 988 calls. But because it was codified earlier, MiCAL does have its own number. However, MiCAL staff will answer the calls that come in on the MiCAL general number, and they will also answer calls that come in on the 988 number, and also texts and chats for Michiganders. So it's the same staff, the same phone system, the same set of integrated care, and both lines just get forwarded and come into the same number. So there really, I don't want us, there's some confusion that there's two separate crisis lines, maybe two separate staff that they compete with each other, but they're not. It's all the same set of staff. It's all coordinated. In fact, we probably will spend a lot more effort advertising 988 and that number than we will MiCAL, because 988 is very easy to remember. Next slide, please. So here's a little bit about the history of MiCAL. Again, it was developed out of the House Cares Task Force and the Michigan Psychiatric Inpatient Discussion. It was built on SAMHSA's National Guidelines for Behavioral Health Care, which is also the foundation for 988, so they align perfectly. It was funded in 2018 and formalized into law in 2020. We held an extensive request for information process and request for proposal process in the summer of 2020. And we awarded the contract to Common Ground, who has over 50 years experience operating a crisis line. They also operate a mobile crisis team and crisis stabilization-like facility. So they've been doing crisis for a very long time, and they are out of Oakland County. But they are serving, they will serve the whole state. So next slide. So a point I want to emphasize about the MiCAL model is that in Michigan, MiCAL will be a clear access point for all Michiganders in crisis or distress and who don't know where to go for behavioral health help. As many of you know, our behavioral health services system is very diverse in Michigan based on payer type, region. It looks really different across the state. And those differences can be real strengths of the system in that they've been tailored to the local regions, and they're built on the strength of local providers. But it also can be really confusing if you don't really know that system well. So what MiCAL is set up to do is it's set up to be the place that will keep track of how each of those crisis services systems work and how those behavioral health services work in each of those regions. And it can be the one place that everyone in Michigan can call very easily to get to the help they need when they don't know where to go for care. So again, it's going to link Michiganders to those crisis services and behavioral health services, and then still allow that regional tailoring, because again, there's a clear access point through MiCAL. Next slide. So MiCAL is not a replacement for the CMHSP crisis lines and specialty crisis services. MiCAL is not, people are not required to go through MiCAL or 988 to access services, whether or not they're in a crisis. And MiCAL isn't going to require CMHs to implement a whole bunch of additional face-to-face crisis services. We do have other initiatives where we're working with the CMHs on that, the ones that I talked about earlier with mobile crisis and CSUs. I make this point because the CMH crisis lines have been around for a long time, and they provide a direct route of contact for people that receive CMH services to get the crisis care they need. And it is really, as we know, it's very important that that crisis care is strongly integrated with their ongoing services. That's a best practice. And so somebody, let's say there's somebody, a Michigander has received CMH services in the past, and they are in crisis and they want to call that CMHSP crisis line, they can still call that line, or they can choose to call 988. And if they need to receive services from the CMH, then 988 will get them there. So either way is the right way. But we wanted to point this out, that MiCAL is not a replacement for CMH crisis lines or the specialty crisis services. What eventually, in a couple years, MiCAL will start to provide some of the after hours coverage for CMHSP crisis lines. We do that as a pilot right now in the Upper Peninsula. So instead of forwarding their lines to another third-party private entity, they forward them to MiCAL in the evenings and the weekends. Next slide, please. So this is a pictograph of MiCAL's services. The crisis specialists have specialty training. And again, we can support Michiganders through phone, chat, and text. Right now, we have paused our text. We are going to roll text and chat out a little bit later once we get the phone system all set up and ensure that infrastructure is in place. Part of the service that MiCAL offers is crisis support. And a part of that is anytime somebody has a crisis or they express any kind of crisis, feeling like they're in crisis, the crisis specialists provide a safety assessment, which is an evidence-based tool that walks the person through an assessment to determine level of risk. And then they help safety plan and take other steps. Again, they can activate face-to-face crisis services when they need to, and then they provide referrals for mental health and substance use services. Anytime we can make a warm handoff, we do that. We also have ways that we can give the caller the referral information either verbally, or we can send it to them through an email. Another important piece of MiCAL is that we provide follow-up calls. So when somebody calls MiCAL and they need a referral to someplace, then MiCAL asks that person, hey, can I follow up with you to make sure that you get connected to the care that you needed? And then they call that person back, and they will continue to call that person back until that person is successfully connected to care, obviously with the person's permission. So I mentioned earlier about how important care coordination is with crisis services. MiCAL is really built on this air traffic controller model that once a call comes into MiCAL, we will hold on to that person until they're safely connected to that next step in care. And that's what I was talking about, the referral and the follow-ups. So one of the things that we're doing right now as we roll MiCAL out is we are developing care coordination protocols with the community mental healths in each area, and also with the state demonstration CCBHCs. We will also build those same care coordination protocols with contract providers of crisis services. I mentioned that that's going to be built into the funding for, or the requirements for like mobile crisis and for crisis stabilization units, that they connect with MiCAL so we can activate those services. MiCAL is built on a customer relationship management platform. I think of it as like a big electronic health record. It's like a big database. And we have integrated 211 data into that so that our call specialists have that resource data that they can readily access. And then we also we're integrating another behavioral health resource database as well. It's called MyCare, and that's something that Lara is rolling out. The customer relation management system is well protected, and it meets all the confidentiality standards. We are also able to get lots of data reports, some very valuable data information from that CRM, because it has a strong reporting functionality. We are a little over a year old. We went live in the Upper Peninsula in Oakland County in April 19th of 2021. And we've been working on just setting up those systems, building out the CRM and a number of things since then. And so we're just starting now to get some of the data from the CRM and to build out some more of those data reports. Okay, next slide, please. So MiCAL actually has a number of lines that it provides support for. There's the Michigan Crisis and Access line. And then there is the 988, which is the new 3-digit dialing code for the NSPL line. And then there's the Michigan Warm Line. The Warm Line uses the same platform, that same customer relationship platform. It has different staffing because they're all certified peers and recovery coaches. And of course, it has a different phone number. On the back end, the Warm Line staff can reach out for help if there's a crisis situation. They can reach out for consultation, or they can reach out for help to provide the person, if there's a person in crisis that needs more support than the Warm Line traditionally offers, they can make that connection. We're also standing up a crisis line specifically to support first responders called Frontline Strong, and it will start in the next well, it won't start spring 2022, but we anticipate it starting in the next couple of months. And then, as I mentioned earlier, we do provide some CMHSP after hours coverage for the Upper Peninsula as part of an after hours pilot. And so at this point, I'm going to turn the presentation over to Rachel to talk about 988.
Thank you, Krista. So let's talk about 988. So we wanted to stress again, 988 is not a new crisis line. It is a new 3-digit dialing code for NSPL. There is a federal trend to develop crisis services system as evidenced by the Crisis Now Initiative, SAMHSA Crisis Services Standards, and 988. Michigan Crisis Service System work is in alignment with these initiatives. Prior to 988, Vibrant, who manages NSPL relationships, worked directly with the centers. But now Vibrant and SAMHSA have involved states in a leadership role in planning and implementing 988. Part of the reason for this is to encourage states to integrate 988 as part of their crisis services system. Vibrant is contracting with national backup centers to provide backup for text, chats, and calls. And we are currently rolling 988 out as a soft rollout, which essentially means that there's no current focus on marketing. Instead, we are focusing on implementing the infrastructure for 988. So Vibrant privately funded the planning process and invited all states and territories to participate. Michigan legislature placed Michigan ahead of many states on 988 with codifying and funding MiCAL through PA 12 of 2020, which Krista had mentioned before. Both 988 and MiCAL are based on SAMHSA's national guidelines for behavioral health crisis. Michigan 988 implementation plan stays in alignment with PA 12 of 2020 with MiCAL as the statewide crisis and access line, answering 988 calls, texts, and chats. In addition to promoting statewide consistency, this also brings the benefit of approximately a 30% reduction in the size of workforce needed to staff 988 in Michigan. The implementation grant provides funding for 988 staffing and for the infrastructure development. So what is in store for calendar year 2022? We have a coverage plan, which is MiCAL providing statewide coverage. We are developing an implementation plan, which has some technological components. We were actually very lucky in the fact that Common Ground is a national backup center for chat and text. And MiCAL will provide 988 statewide coverage for calls, texts, and chats with 2 exceptions. Those 2 exceptions are Macomb County and Kent County. Each of these counties has a CMHSP that is an NSPL affiliate and has asked us to continue to provide primary coverage for 988 calls using their own existing funding. MiCAL will provide backup coverage for calls and primary coverage for chats and texts in these 2 counties. In our planning process, the stakeholders emphasize consistent services across the state. Michigan 988 centers will work together to ensure that the response to 988 contact is consistent across the state. Any centers answering 988 calls originate from Michigan will need to be able to meet all 988 requirements specified by Vibrant. All must meet jointly developed Michigan standards, submit performance metrics to Vibrant and MDHHS, and coordinate with local crisis service providers. MDHHS will have an ongoing relationship with 988 stakeholder groups. While members deemed regular meetings unnecessary at this present time, they will want to stay informed and involved. There are clear roles for them related to marketing 988 and reviewing the performance of Michigan systems. Email updates on the crisis service projects are being provided on at least a bi-monthly basis to 988 stakeholders. And people that are reaching out to inquire about 988 are being added to a list of stakeholders that we can contact later. So this is the rollout. So we are rolling out the MiCAL general number and the NSPL coverage. As we roll out, we are developing coordination protocol with CMHSPs and state demonstration CCBHCs, as well as publicly funded crisis service providers. So as you guys can see, we are currently in 5, so Mid-State Health Network, then we'll progress on to 6, 7, 4, and 9. So for 2023, as mentioned kind of before, we'll be focusing more of efforts on marketing, and marketing will begin at the end of 2022, beginning of 2023. Additionally, we wanted to target outreach and support for high-risk callers, providing listening sessions with people from typically underserved groups that I will kind of discuss in the next slide. So MDHHS will develop an in-kind marketing campaign for 988, which will rely heavily on interested partners. The diverse group of dedicated stakeholders have been identified, but we intend to identify further channels just because we were just in the very initial process. For the listening sessions, 2 listening sessions were held with people who've experienced suicidal thoughts or behaviors, accessed crisis services, contacted a crisis line, or lost a loved one to suicide. The sessions were held on April 29th and May 4th, and participants had shared what works well in the current system and what does not work well. Participants were also asked what kind of response they would want for themselves or their loved ones if they had called 988. The discussion included a focus on what features 988 should include, and they also shared specific populations and cultural characteristics that 988 needs to be prepared to support. MDHHS will also request meetings with leaders of federally recognized Indian tribes or their designees to learn about the crisis services needs of the members of their nations. In addition, MDHHS will host listening sessions with typically underserved groups and high-risk individuals to ensure that 988 meets the needs of all Michiganders. MDHHS has already had initial sessions with Michigan Veteran Affairs Administration and will host a follow-up session. And as far as marketing materials, our plan is to engage the regional call centers, MiCAL, MDHHS, and other stakeholders to identify existing materials and marketing campaigns to which 988 can be added. The campaign may or may not include the NSPL number. And then this is kind of a question we wanted to pose to you all. For your thoughts and feedback, how do we combat stigma? And with that, how can we encourage people that they should call when they are in distress and not wait until they are suicidal or in major crisis? So we'll have that as part of the question, and then we're also opening the time now for questions and comments.
Okay, thanks very much. I believe I'm going to conduct and direct the question and answer period. That was an excellent presentation, a little before when we expected it to be finished, so thank you for its brevity. I want to ask the first question, and then we have several questions I'll moderate in the chat if people don't mind. 988 is a complex activity with many moving parts. Over time. So it's not going to be ready in its full implementation on day one. Where will we find the first successes, and where will we find the biggest barriers to successful implementation during the first year? Then let's start that first year, July 19, or July 17 of 2022, when they actually goes online nationally, if you don't mind.
So I'll take us to go ahead and answer this. So I really like that you said that it is a big undertaking. Building out all these crisis services in Michigan is a big undertaking. And while we want them to be ready now or, in the next few months, it's going to take years to develop this system so that it's really instituted in our state and is available for all Michiganders. In terms of what I see for 988 and the biggest successes is, I think it will be a success when most of the NSPL, when most of the calls to the National Suicide Prevention Lifeline in Michigan are answered by staff that are in Michigan, that are familiar with Michigan resources and able to connect the people that need some type of face-to-face crisis support, in at least that they can connect them to those resources. So that would be the biggest success is that first year, is if we get, that infrastructure fully ingrained and can answer all those calls. The biggest challenges are that while we can roll out 988 and we can have that call center in place, there are many other services that we need in Michigan to really impact behavioral health and to improve the behavioral health of our Michiganders. So mobile crisis is a need, crisis stabilization units are a need. People need basic behavioral health care, referrals to outpatient services. Workforce is a huge issue right now, and that's for all payer types. So I think that first year in particular, connecting people to those services, those other services that they need, is going to be a challenge.
Okay. Thanks. That's very interesting. Our first question in the chat was, it's exciting to hear MiCAL is open to connecting with face-to-face mobile crisis teams and crisis stabilization unit. If a community has an active crisis unit, mobile crisis unit, and a co-response team, how will they start to receive calls through 988 or MiCAL? And when will that occur?
Well, we are rolling that out as we roll MiCAL out. And so what we're focused on, that first layer that we're focused on coordinating with are the CMHSPs. So there are some communities that do have mobile crisis teams. And so what we're setting up is that when somebody does need that support, and right now, mobile crisis is primarily provided to children who have Medicaid. And so when it's a child that has Medicaid, then we are setting up that care coordination protocol that we can activate mobile crisis. The way that it works is the person would call into MiCAL or the 988 number, and we would support them through that whole crisis support safety assessment. And then once we figure out that they need something besides the phone support, then we would look at the options in the local community. And we actually have service cards that are built in the crisis or in the CRM, our customer relations management system. So the MiCAL staff can actually, they can search crisis support and it pulls up what crisis services are available in that region. And so let's say that, again, that maybe it's a site that has a state demonstration CCBHC where mobile crisis will be more readily available. So what we would do then is there's instructions right on that service card where the MiCAL specialist can quickly see how to activate that mobile crisis. So they would call that, the contact for that mobile crisis team, they would do a warm handoff with that person to the mobile crisis team. They would also send an encounter note through the customer relations management program. There's a portal that our partners can get on where they can get the encounter note in real time and a referral will come through. Then once that's basically how we would activate that mobile crisis. And then what we would do is we would also still follow up with that person. We'd ask them, hey, do we have permission to follow up with you? What's a good time? What's a good number? That kind of thing, to ensure that when we're calling somebody that it's a safe number to call back on. And so we'd follow up with that person to make sure that, that they got that mobile crisis, that they actually got connected to care. So we're doing that follow up with everyone. So that's how we would work that out.
Yeah, okay. Thanks. One question that came in was that some communities don't have mobile crisis services or crisis response units.
Mhm.
When will that be addressed in this process? I know you spoke a little bit to it, but can you say something more about that?
Yeah. So that's going to be a while in coming. We are working on it. We are working on standing up all three of these components at the same time. So I mentioned that the Diversion Council got some diversion funding. That was something the legislature put through to pilot some mobile response teams. There are also, I'm going to try and remember the exact number, there are 13 state demonstration CCBHCs, which will offer mobile crisis. Then there is also an enhanced Medicaid match that MDHHS is going to explore. And so we need to identify the need for mobile crisis. We need to identify the infrastructure. And right now we're working on developing a model, ensuring that it meets Medicaid requirements, also ensuring that it can work in all areas of Michigan. Rural areas are a real challenge, and workforce is a real challenge.
Yeah, I know that some CMHs are not really interested in providing mobile response units or crisis stabilization units. Will you then do requests for contract on non-CMH organizations? Is that a possibility?
I will say that's a little soon for me to answer that question. What I can tell you is that in any systems work, we have people that are those innovators that are ready, systems that are ready to roll out those services, that maybe they have resources, workforce. There's just some areas, to be blunt, it's easier to stand it up in an urban area. Sure. Because there's more people. so they have more need, and so that mobile crisis team's busier. There's just a number of reasons. So where we're at right now is as we stand up these services, we are having ongoing continuous conversations with stakeholders and talking with them about how we can stand this up in such a way that it really benefits Michiganders and that it's a doable service. And so so for example, the Crisis Stabilization Unit they have a very extensive work group that provided some great feedback up front on a model. And we came up, it's a strong model. And right now we're drafting the certification criteria, which will go back to that same work group to provide feedback on that certification criteria. So we are doing our best to have conversations with a wide group of stakeholders, including really emphasizing that voice of people with lived experience as we develop these services. So that's what I can tell you.
That's a great answer. Thanks. Here's another time bomb. Is 911 a backup referral when 988 is at capacity?
So that is another part of our 988 grant. And you know what, actually, Rachel, do you want to take a stab talking a little bit about our 911 988 coordination? Do you want to talk a little bit about what we're doing on that, or do you want me to go ahead and take that one?
I will let you go ahead.
Okay.
On this one, just you're doing a great job.
Sorry.
I'll take one next time.
Okay, you're fine. You're fine. So, so with what we're working on is a coordination plan between 911 and 988. And again, none of these things are easily instituted. So we are working on a 3-step plan. The first step is to coordinate with 911 around active rescues. So when somebody gets to the point where not only do they need some type of face-to-face crisis support, they need something right away. Maybe there's a physical health issue, or they're in the, they might be in the midst of committing suicide. Basically, if they have that crisis moment, then what we will do is we will call 911. And so we're coordinating and developing coordination protocols with them. And so that's phase 1 of the plan. Phase 2 of the plan is to work together with 911 to develop some materials around how to educate the public on when to call 911 and when to call 988. And then it will be working with our law enforcement staff and first responders on, getting that 988 number out there. So if they go out on a call where there is a behavioral health situation, and then they could basically give that information and say, hey, here's another number that you can call under these circumstances. Because 988 and 911, they're not replacements for each other in that way. 911 does not offer that behavioral health component, and 988 isn't going to offer that real-time, in the moment, physical emergency response that some people need. But the third step to the coordination between 911 and 988 will actually be partnering between the two of them to set up a diversion protocol, so that if calls come in on 988 that need to go to 911, that we can send them over, and vice versa. That third one, there is a group at the federal level that is working on diversion protocols as well, and coming up with some best practices around that. And we are watching that federal work. There's a liability involved, technology involved, cross-training. I was just talking to our 911 state administrator the other day. She's Joni Harvey. She's a great partner. And she was mentioning some terminology. And I can't remember what she said, but I was like, no, that we don't use that. She goes, you don't? And I said, no. And so we've learned already from our small work group that we need to educate each other around behavioral health services and then the 911 services. So you got a really long answer to that question.
That's a hard question. Here's a question that came from our members at Fresh Start Clubhouse, whom we discussed some of the issues that they're concerned about. Police have been called by mental health staff when people in their care or in their relationship have excessively disruptive behaviors at their workplaces. And even though police do not have the capacity to help, in addition, professionals, including EMTs, sometimes give the wrong advice about handle crises. And sometimes consumers seek emergencies care when it's not appropriate. How can 988 train professional staff, consumers, and others about who to call and where to go when a crisis occurs that's not an emergency?
Well, that's one of the things that I love about 988 when Rachel mentioned that it's not just a call line, but SAMHSA's saying, hey, this really needs to be a crisis system of care. And Michigan is very much working on developing that crisis system of care. So there are other initiatives in Michigan that are working with where law enforcement and behavioral health are coming together to doing some co-training. And there's some communities where they've been doing this for a while and they have a co-responder model. And so what 988 will do is it will work with 911 to provide education to the public on when to call 911 and when to call 988, and we will get it out there. And then we're also going to partner with and rely on some of these other crisis services initiatives to provide that more in-depth training that you're talking about or that they mentioned for first responders. Okay. Around behavioral health and communities are setting this up. It is going to take some time, but we're headed down the right path of working together.
That's real.
Mark, I think we have time for one more question.
Okay, good. I want to include this because this also came up with our Fresh Start people members. I'll just read this question. I feel family or caregiver education is key when seeking help before a person is in acute crisis, seeking help before the crisis. Right now, 911 is called when a person is acute. The community feels nowhere to call when the symptoms of distress that are not crisis are evident. What about the pre-crisis training? And I think that's redundant with the other questions, but still important.
That is a really important question and not at all redundant, in that I think one of the things that's important about 988, and that was one of the questions that we would love feedback from you on, is how do we advertise 988 in such a way, and how do we advertise MiCAL in that we want people to call when they're in distress. We want them to call earlier. And so one of our challenges will be to develop community education and get the word out there that family members can call 988. They can call that 988 or the MiCAL number, either one, again, same staff, and get that support as well, and get some information on maybe, where they could guide a family member to go to. So that really is the role of 988. People should not wait until they're in crisis. It's also very much for people that are in distress. In fact, most of our callers so far on the NSPL and the general number, they've been in distress. They don't self-identify as crisis, which is great.
Pat, I'm going to just ask one quick one. How can people
okay.
get involved in this process?
That's great too. So Rachel, do you want to talk? I'm going to give that one to you actually, because I know that's one of the things that you're going to do for 988.
Well, in your answer, Rachel, could you also indicate how someone might be interested in helping taking calls and what kind of training they might need?
Yeah, so if you want to get involved with 988, we are currently in the process of collecting information from stakeholders. So if you want to, I will be dropping our email. Well, I can just drop it right now. That was our references. But if you want to contact me with your information, we are creating a list of stakeholders. As I kind of mentioned before, we're not working on marketing right now, but we still would love to have if you're interested in being in the marketing or anything else, just feel free to email me with your information and I can contact you with more information on that. And then if you want to be involved in taking phone calls, I believe that would be part of like Common Ground. I think you'd probably have to reach out to them and see if they're hiring, which they usually tend to be. And I can also connect you with them and their organization.
Thank you, Rachel. Well, I would like to thank both of our speakers. We are very grateful that you came to speak with us tonight. We had a very good turnout. We're all very pleased to be together with you. There will be a PDF sent to all the registered attendees of the PowerPoint that was given. In addition, the session was recorded. That's going to be edited a little bit for time because we started a little early with some practical things. And that we'll send a link out as well to that. I believe it will be on the MHAM website. And I'm not sure if Fresh Start or Washtenaw NAMI will have it as well, but we'll send that information out to everyone who's registered. So hopefully, Krista and Rachel, we can reach out to you again, maybe in another 6 months or so. Will you have updates for us? Perhaps we can have you back for more information. And again, thank you everybody for joining. I'm going to sign us off, and everyone have a great evening. Thank you very much.